This video is reviewing the anatomy of the spine and the neck. There will be some overlap between this section and the section that talks about the spine and the trunk. So we're going to talk about the bony anatomy of the spine, but the muscles that are more isolated to the entire spine we'll talk about with our trunk section, and we'll focus on just the muscles that are limited to the neck with this video. So starting with the spinal column and the vertebrae, we have 7 cervical, 12 thoracic, and 5 lumbar vertebrae. And the vertebrae in each of these sections have slightly different characteristics. So we'll go through each of the different vertebrae, or the sections of vertebrae on their own individually, but overall there's some commonalities between the 3 that we can discuss here. So the cervical spine has 2 vertebrae that are named individually. So the very first cervical vertebrae, or C1, we call the atlas, and C2 we call the axis. So we have 2 kind of distinct joints that we'll talk about on our next few slides related to those. And then we have some other kind of key vertebrae. So C7 is the vertebrae, and this is the largest prominence. If you run your hand down the back of your neck, and you can feel that one large vertebrae that's on kind of between your shoulders, that's your C7. And then T12 is the last vertebrae where we have ribs that attach. Off of the medial and the lateral side of each of our vertebrae, we have transverse processes, again, that are associated with each of the individual vertebrae. And then off the posterior side of the vertebrae, we have spinous processes. And again, that's with every vertebrae, all the way from C1 down to L5. We also have the sacrum and the coccyx down at the most distal portion of the spine, but we're not going to talk about the pelvic section essentially until we get to our next section. So for this video, we're just focusing on the spinal column, and we'll also talk about the ribs. So the anterior side of each of the vertebrae is called the body, and then between each of our vertebrae, there are intervertebral discs, and we'll talk about those a little bit more in class. Our ribs, again, range from our first thoracic vertebrae down to our 12th thoracic vertebrae, corresponding with the number of ribs that we have. And between each of our ribs and our sternum is what we call costal cartilage. So again, each of our ribs has a piece of costal cartilage that connects it to our sternum. And then our bottom 4 ribs are what we call floating ribs. So these are ribs that are just essentially connected to a chunk of costal cartilage, and they don't have a direct connection to the sternum. The sternum sits directly opposite from the spine and provides a connection point for our ribs. The top of the sternum, this area we call the manubrium, and the bottom we call the xiphoid process. Up at the very top of the manubrium, we have this area called the jugular notch. So the skull is divided up into a series of what we call cranial and facial bones. So the cranial bones are usually considered to be kind of around what we would call the skull, and then the facial bones are related more to the face. So moving around the skull, starting on the front, we have our frontal bone. On either side of kind of the main part of the skull, we have the parietal bones. And then on the posterior side, we have the occiput. This section, there's a couple key areas of the occiput we need to note. This is the superior nuchal line, and that'll be an important prominence for the origin of some muscles here, as well as the external occipital protuberance, which is this in front of that is our sphenoid location right here, and that'll also be important for the attachment for some of our muscles related to the parietal. From a side view, here we have the temporal bone that comes all the way down. And then back here is the temporal bones as well. In front of that, right here, we have the parietal bone. And so we can see a little bit here, and then you can also see the parietal bone kind of in the back, or what we would consider to be the back of the eye socket. We also note that the frontal bone makes up the top half of the eye socket. The front part, or kind of the anterior portion of the side, right through here, is made up by the zygomatic arch. See that here as well. Again, that goes all the way back and kind of connects to our temporal bone and then comes up and forms the lateral side of the eye socket. The inferior portion of the eye socket is created by the maxilla, which also extends down onto kind of what we would consider the upper lip. And then the bottom jaw is the mandible. So again, we have the maxilla and the mandible, and we can see the maxilla here as well, and the mandible. So as I mentioned previously, C1 is also called the atlas, and this is one of the unique cervical vertebrae along with C2. So it has a couple of different structures that we don't see on the other vertebrae that we're going to talk about here. So the first thing being the posterior tubercle. So on a normal vertebrae, we would call this the spinous process, but on the C1, we call it the posterior tubercle. The area between the posterior tubercle and kind of the body of the vertebrae is called the lamina. And then off to the side, we have a very small transverse process, especially when we consider it to the size of the transverse process on the other vertebrae. So again, here we have our posterior tubercle, which would essentially be the same thing as, again, a spinous process if it were another vertebrae. We have our transverse processes off to the side. And then we call this area kind of on the front the anterior surface. So here we have an articular facet for the odontoid process, which is the small process that comes up off of C2 that our C1 articulates around, and we'll see that joint here in a second. On the top surface, we have superior articular facets, and this is where our occiput will actually set when we look at the atlanto-occipital joint. And then we have these two small openings that are called transverse foramen, and this is for our spinal nerves to run through. And then our main foramen or opening is called our vertebral foramen. We also have a small groove that runs on either side right in front of our superior articular facet for the vertebral artery. And again, the lamina, which was this area between the posterior tubercle kind of and the body, would be right here on the top view. So those are both the lamina. So the articulation between our skull and C1 is called the atlanto-occipital joint. So essentially what this joint is just the occiput sitting on top of those superior articular facets on the atlas. So our occiput just comes down and rests on those flat surfaces and really isn't all that incredibly stable. So our entire skull is balancing just on this one small articulation that we can see here between a vertebrae and the posterior aspect of our occiput essentially. So our C2 is the next vertebrae, and this is the base for what we call the atlantoaxial joint. So we had talked about on the C1 how we had the articular facet for that odontoid process, and this is that process here. So we can see that process sticking up, and this is the surface that would articulate with our C1 along that articular surface. So the posterior side of the anterior surface of the C2 articulates with the anterior side of the anterior surface of our C1. Again, we have superior facets, and this is where the C1 would rest on the C2. We still have vertebral foramen, but this time they're off to the side on the transverse process. And here we don't actually have, we actually have a spinous process, like we will see with the rest of our vertebrae, so it starts to look a little bit more normal. And that would be right here. And then again, we have that lamina region. So that's just the region between the posterior aspect and kind of the anterior articular processes on the vertebrae. And we'll see that on the rest of our vertebrae as well. So the transverse process again has our vertebral foramen, and the transverse processes kind of extend downwards on our C2. So they're just shaped a little bit different than we saw with our C1. And then again, we have that vertebral foramen where the spinal cord runs. So the atlantoaxial joint again is really unique. So here's that odontoid process. On C1, we have that articular surface for the odontoid process, and it's the anterior side of the anterior surface that's articulating with the posterior side of the anterior surface on our C2. So here's that posterior tubercle and our spinous process. We have our transverse process with our transverse foramen. And then same thing, transverse process with our transverse foramen. And then through the middle of both structures, we have that vertebral foramen, again, where the spinal cord would run. So again, this is important to remember. This is our anterior surface. So the odontoid is anterior, and then our C1, rotates around kind of from a posterior to an anterior direction. So students tend to struggle with this concept. So again, remember that the odontoid is always anterior, and then the posterior tubercle on C1 rotates from posterior to anterior, kind of wrapping around. So as I mentioned, there are a few distinctions between the different vertebrae. So quickly, we're going to run through those. One of the biggest things when we look at the cervical vertebrae in particular is that we have our transverse foramen. Again, and this is where our vertebral artery and nerve run. So that's specific just to our cervical vertebrae. Then we have, if we look at the area just beside that, we have two different tubercles. So we have an anterior tubercle and a posterior tubercle. The big thing again to remember when you're looking at the vertebrae is to always remember that the body is the anterior portion and the spinous process is the posterior portion. So if we're looking over here, we have anterior and posterior. So that anterior and posterior tubercle, if we look at that guy, they're a little bit trickier to see on these pictures, but it would be right here would be the anterior tubercle. And then back here would be the posterior tubercle, and this surface would be the facet. And here's our facet on the top view. Okay, so again, those facets are where the vertebrae sit together, what creates the joint. The area between the lamina and kind of the facet, or sorry, between the spinous process and the facet is called the lamina. That runs through here, and that would be that area here, would be our lamina. And then we also have a transverse process, which is essentially created by our posterior tubercle. So again, if we look from kind of our side view, we have our spinous process. Our transverse process would be kind of right in here. We have our articular facet, again, which is our joint between the vertebrae. We have the body that would be here. And then we also have inferior articular facets. So the ones on the top view are our superior articular facets, and then on the bottom side of the vertebra, we also have inferior articular facets. So as we move down the spine, our vertebrae start to look a little bit different. So some of the major distinctions when we look at the thoracic vertebrae compared to cervical is the angle of the spinous process. So we have that downward slope kind of at 45 degrees on our spinous process that exists in the thoracic vertebrae when we compare it to the cervical vertebrae. And then the other big distinction again is that we no longer have that vertebral foramen. So we still have the body, again, still on the anterior side. And the body here is a lot thicker and a lot larger than we saw with the cervical vertebrae. We also still have our vertebral foramen down through the middle. Again, that's where the spinal cord runs. And then we have articular facets again. So the articular facets on the thoracic vertebrae are also on more of an angle. Where they sat essentially straight up and down on our thoracic vertebrae, they sit on an angle in the vertebral. So we would have superior articular facets here, and then underneath our inferior articular facets would be right about here, and you can kind of imagine how those two would sit together. Here's our transverse process, and this is the transverse process from the top view, again coming off of the side. The other process that we have on the thoracic vertebrae that we did not on cervical is what we call costal facets. So our costal facets are right here and then down at the bottom, and this is where our ribs articulate. So remember that the ribs originate on the thoracic vertebrae. So we would have one rib that sits on the superior costal facet, and then the inferior costal facet of the next vertebrae would also contact that same rib. So same thing, our inferior costal facet, and we would have another superior costal facet, and we would have one rib that would sit on those two. So we have a total of 12 pairs of costal facets through the thoracic vertebra. So moving even further inferiorly as we get to our lumbar vertebrae, you can see here how much the mass is increased of that vertebra. So it's gotten a lot thicker, and the body has gotten a lot larger. So remember, we locate the body, that's the anterior side. So we have our spinous process off the posterior side, and you can see here again how much thicker even our spinous process has gotten when we compared it to our thoracic spine. It also comes more in a straight line out from the body, and we have less of an angle like we saw in the thoracic spine. We still have our vertebral foramen again, and it's starting to narrow here because our spinal cord is getting smaller as we move down. So we have a slightly smaller vertebral foramen with a larger body and vertebra. We still have our transverse processes coming off of this side, and here's the transverse process here. And then again, we have those articular facets. So we have superior articular facets here, and then on the bottom side here would be our inferior articular facets, again where those two things articulate and rub together, and here would be our superior articular facets. We also have the lamina, just like we saw in both cervical and thoracic, and then again the body that sits on that anterior portion. So jumping into the muscles of the neck, first we have the splenius capitis. It originates from the ligamentum nuchae and the spinous process of C7 through T3. Now, the ligamentum nuchae is a structure that we'll talk about in class, but essentially it's one large ligament that connects the spinous processes as well as the external occipital protuberance on the base of the skull. And so it runs all the way from the base of your occiput all the way down over top of all of the spinous processes and kind of between the processes of the vertebrae between C1 and C7. Your splenius capitis inserts onto the mastoid process and the lateral portion of the superior nuchal line. It's innervated by the dorsal division of the cervical nerve. Splenius capitis causes rotation and lateral flexion of the head and neck as well as extension. Splenius cervicis sits just inferior to splenius capitis. It originates on the spinous processes of T3 through T6 and inserts into the transverse processes of the upper cervical vertebrae. It is also innervated by the dorsal division of the cervical nerve and also causes rotation and lateral flexion of the head and neck as well as extension. The rectus capitis posterior major is the first muscle in the group of muscles that we call the suboccipitals. So this one originates from the spinous process of the axis, or C2, and inserts on the inferior nuchal line of the occiput. It's innervated by the suboccipital nerve, and like all of the other suboccipital muscles, its action is to rotate the head to whichever side it's on, so only the right or left side can work at a time. The second muscle in the suboccipital group is the rectus capitis posterior minor. The rectus capitis posterior minor originates on the tubercle of the posterior arch of the atlas and inserts on the inferior nuchal line of the occiput. It's also innervated by the suboccipital nerve and causes rotation of the head. The oblique capitis superior originates from the transverse process of the atlas and inserts between the nuchal lines of the occiput. It is also innervated by the suboccipital nerve and causes rotation of the head. The last muscle in the suboccipital group is the oblique capitis inferior. This muscle originates from the spinous process of the axis and inserts on the spinous process of the atlas. It is also innervated by the suboccipital nerve and causes rotation of the head. So again, the suboccipital group is that complex that's made up of the rectus capitis posterior major and minor over on the left-hand side, as well as our oblique capitis superior and inferior. And these muscles collectively cause rotation of the head to either side, and they also help to slightly tilt the head back into extension. The sternocleidomastoid is one of the largest muscles in the neck complex, and it's also the most palpable and kind of most visible and easy to locate. So it has two heads. It has one head that comes from the sternum and one head that comes from the clavicle. So just like with pectoralis major, we call them the sternal head, which is over here, and then the clavicular head. So the sternal head is a little bit more anterior at the origin than our clavicular head is. So the sternal head originates from the top of the manubrium, and the clavicular head originates from the medial third of the clavicle on the top side. The sternocleidomastoid inserts into the mastoid process of the temporal bone and the lateral portion of the superior nuchal line of the occiput. It's innervated by the spinal accessory nerve, and it works to laterally flex and rotate the head and neck, as well as just flex, and then it also helps with inhalation because it helps to elevate and lift the rib cage. The anterior scalene is the first muscle in the group of muscles that we call the scalene. and obviously it's the most anterior of the three muscles. So the anterior scalene originates on the transverse process of the 3rd through 6th cervical vertebrae, and it inserts onto the superior portion of the first rib. The second muscle in the scalene group is the middle scalene. It originates on the transverse process of the 2nd through 7th cervical ribs on the posterior tubercles. And it also inserts onto the first rib. It's important to note here that the middle scalene inserts onto the first rib more posteriorly than the anterior scalene. So our anterior scalene inserted about the midpoint of the first rib, while the middle scalene is more towards the posterior side. The last muscle in the scalene group is the posterior scalene. So this is the only scalene that inserts on the second rib. It actually goes across the first rib. So it originates on the transverse process of the 5th and 6th cervical vertebrae, specifically on the posterior tubercle, and it inserts onto the second rib. So here's the scalenes as a group. So again, we can follow them from anterior to posterior, just simply based on where they're inserting. So anterior is the most anteriorly of the scalenes. It's also kind of the middle in size. Middle is in the middle, again, more towards the posterior side of that first rib insertion. And then our posterior scalene is the only one that inserts down onto the second rib. So collectively as a group, the scalenes are innervated by the cervical and brachial plexus. The posterior scalene is the only one that's innervated only by the brachial plexus. And they work together to do a couple of different functions. So if the ribs are fixed or the rib cage can't move, they help to laterally flex the head and the neck and to rotate the head and the neck. They can also help to elevate the ribs and flex the head and the neck in an anterior direction. So the big thing here, again, remembering is if the ribs are fixed. So the scalenes, because they're attached to the first rib, also have an ability to elevate the rib cage and help with inhalation. But when those ribs are fixed, they're going to contribute to motion at the neck. The masseter is one of our primary muscles of mastication, meaning chewing, and it's one of the kind of the larger muscles that we see just limited to the face. It originates from the zygomatic arch and inserts on the angle and ramus of the mandible. It's innervated by the mandibular nerve via the masteric nerve, and it helps to elevate the mandible or close the jaw. The temporalis muscle is another muscle that also helps with mastication. It originates from the temporal fossa and the fascia over the temple. It inserts onto the coronoid process on the mandible. It's innervated by the deep temporal branch of the mandibular nerve, and it helps to elevate and retract the mandible, so close the jaw and bring the mandible posterior. So the suprahyoids are a group of muscles that are below the mandible, and they insert onto the hyoid bone. So they sit below the jaw and they kind of run posteriorly almost on an angle. So you can see them best or consider them best when the head is tilted posteriorly. Along with the suprahyoids, we'll also have a muscle that's called the digastric, and then we'll have another group of muscles called the infrahyoids that are all related to jaw and neck function. So starting with this suprahyoid group, we have three muscles that fit into this group. We have the geniohyoid, mylohyoid, and stylohyoid. So the mylohyoid muscle is this largest muscle here that runs on an angle. You can see the fibers kind of running in an oblique upward direction, and it sits in the middle of the suprahyoid group. The stylohyoid is this small muscle that's running on an angle here, running upwards, and it's the most anterior of the suprahyoids group. And then posterior to the mylohyoid is a muscle that's called the geniohyoid, and it's a small muscle and it just runs inferior and superior. You can see a picture in your textbook with the suprahyoid group, but it just runs superior and inferior behind the mylohyoid muscle. The geniohyoid and mylohyoid originate on the underside of the mandible, and the stylohyoid originates on the styloid process. They all insert onto the hyoid bone. The geniohyoid is innervated by the hypoglossal nerve, the mylohyoid is innervated by the mylohyoid nerve, and the stylohyoid is innervated by the facial nerve, and they help to elevate the hyoid and tongue and depress the mandible or open the jaw. The other muscle that's visible with the suprahyoids is called the digastric muscle. So this is the muscle that comes down and makes this U shape. This is obviously a digastric muscle. This is one of the rare ones that we see in the body, like we talked about with the muscle shapes at the start of the year. So it comes up from the jaw, both at the origin and the insertion, and then we have this medial, what we call a tendon sling. So we have a little piece of tendon that comes and literally creates a loop, and then the muscle runs through the loop, and it also has a tendon in the middle. So we have a medial tendon on the digastric muscle, and then it also has a tendon sling that's creating that U shape in that loop. The digastric muscle originates from the mastoid process, and it's deep to the sternocleidomastoid and splenius capitis origins. And it comes down through the tendon sling and then goes back up and inserts on the inferior border of the mandible. It's innervated by the mylohyoid and facial nerves, and it helps to depress the mandible. If the mandible is fixed, it helps to elevate the hyoid bone, and then it also helps to retract the mandible. The infrahyoid muscles are a series of muscles underneath the hyoid bone, so they run from the hyoid bone down to the sternum and the clavicle. So we have a few muscles in that group, the first one being the sternohyoid, and it runs straight from the hyoid bone down to the sternum. And then we have the omohyoid, and it has a superior belly and an inferior belly, and it's another one of our digastric muscles. So right here it has a tendon in the middle, and it runs underneath the sternocleidomastoid and the scalenes. Over on the other side, we have the thyrohyoid, and then below that, we have the sternothyroid. So over on the left side of your image, that's where we have the sternohyoid, and then on the right side, this bottom part is the sternothyroid. So there's just a T in there differentiating those two. The sternohyoid and sternothyroid originate from the top of the manubrium. The thyrohyoid originates on the thyroid cartilage, and the omohyoid originates on the superior border of the scapula. The sternohyoid, omohyoid, and thyrohyoid insert onto the hyoid bone, and the sternothyroid inserts onto the thyroid cartilage. They are innervated by the upper cervical nerve and serve to depress the hyoid bone and thyroid cartilage. The platysma is a large muscle that runs kind of over top of the other muscles, really superficially in the neck. It originates on the fascia that covers the superior part of the pec major. It inserts onto the base of the mandible as well as the skin of the lower face and mouth. It's innervated by the facial nerve, and it helps to depress the mandible as well as tighten the fascia of the neck. The occipitofrontalis muscle is the largest digastric muscle in our body. So we have one little section of muscle that sits on the occipital portion of our head, and then we have a small section that sits on the frontal portion. So again, it's the largest digastric muscle, meaning that it has a tendon in the middle that separates the two. So we call this tendon the gala aponeurotic, and again, it separates the two muscles. So both sides of it originate from the gala aponeurotica. The frontalis inserts onto the skin over the eyebrows, and the occipitalis inserts onto the superior nuchal line of the occiput. It's innervated by the facial nerve, and it serves a purpose to raise the forehead and wrinkle the eyebrows. Raise the eyebrows and wrinkle the forehead, and that's more specifically the frontalis. And then the occipitalis works essentially to anchor the gala aponeurotica fascia posteriorly to limit the movement of the skin of the forehead. The pterygoid muscles have a medial and a lateral muscle. So the medial pterygoid runs a little bit more vertical than the lateral pterygoid. So the lateral pterygoid has kind of two sections, and the fibers run more horizontally, whereas the medial runs more on a superior inferior type of direction. So the medial pterygoid originates on the medial surface of the lateral pterygoid plate of the sphenoid bone and the tuberosity of the maxilla, while the lateral pterygoid originates the superior head or the top portion from the infratemporal surface and crest of the greater wing of the sphenoid bone, and the inferior head comes from the lateral surface of the lateral pterygoid plate of the sphenoid bone. Medial pterygoid inserts onto the medial surface of the ramus of the mandible, and the lateral pterygoids insert onto the articular disc and capsule of the temporomandibular joint, as well as the neck of the mandible. They're both innervated by the mandibular nerve, and the medial pterygoid serves to laterally deviate the mandible to the opposite side that the muscle exists on. So because it's located more medially than the mandible, when the mandible contracts, it would pull the jaw to the opposing side. So the right side would cause deviation of the mandible to the left. And then if both muscles are working together, it helps to elevate and protract the mandible. And same with the lateral pterygoid. The longus capitis originates on the transverse processes of C3 through C6, and it inserts onto the inferior surface of the occiput. It's innervated by the ventral rami of C1 through C4, and it serves to laterally flex the head and neck, rotate the head and neck, and flex the head and neck. Longus colli originates on the bodies of C5 through T3, and the transverse processes of C3 through C5. It inserts on the tubercle of the anterior portion of the atlas, the body of the axis, C3 and C4, as well as the transverse processes of C5 and C6. It's innervated by the ventral rami of C1 through C7, and it serves to laterally flex and rotate the head and neck, as well as flex the head and neck.